Presentar nuevamente a la doctora Julie Gaster Foster, ya fue presentada y nos acompaña en este momento con la segunda conferencia para ella, que es nuestra última conferencia de este bloque de la mañana antes de salir a un receso, y en esta oportunidad la conferencia se titula Impacto de la citometría de flujo en el diagnóstico de leucemia y linfoma pediátricos en países de ingresos bajos y medianos. Entonces, quiero darle nuevamente la bienvenida y los dejo con la doctora Julie.
Gracias. Más inglés. Lo siento. So we're going to round out this little pediatric cancer session with a discussion of flow cytometry. And I want to thank Dr. Fonseca because she emphasized something that maybe is not obvious. If we don't have a good diagnosis, we don't have good treatment. And so it seems obvious to all of us, but if all of you could relay that to the governments in Africa, I would be very grateful. So we're going to switch and talk a little bit about flow cytometry. Maybe just refresh your memories from medical school about this technology and why it's so important in pediatric leukemias and lymphomas. So I can skip some of these original slides. I wasn't sure whether it would be the same audience or not, but my friend Haley is back, but just reminding you again of some of the presenting symptoms of leukemias that you may see in kids, and then what our typical workup is. And you see at the bottom, it's standard for us to get flow cytometry and then that molecular workup. And as you heard in brain tumors, what I could get in my little bit of Spanish, you know, that diagnosis is so critical, and brain tumors really exemplifies why we push so hard for that molecular analysis. So flow cytometry is a technique that was discovered in the 60s. It really measures a number of things within one assay. One is it can tell the size and morphology of cells, as well as key to what we're going to talk about, can detect cell surface markers that are really important during development. It's really the backbone of leukemia diagnosis in developed countries. It's quick and accurate, so you can get a result within a few hours, and it doesn't require a tissue biopsy. So one of the things I didn't mention this morning, but we do have a lot of challenges with getting biopsies, with getting surgeries, et cetera, in low-income countries. And so this is a technique that can be used off of blood or bone marrow, and also fine needle aspirates from lymph nodes, which is important in our lymphoma diagnoses. We can access the data remotely, and so again, when we think about training, we have a lack of hematopathologists, as I mentioned, and so we're trying to train additional folks in flow cytometry interpretation, but the data can be accessed online, and so we can get support from elsewhere. So how does flow cytometry work? The cells are mixed with sets of antibodies. We call them panels of antibodies that are conjugated to fluorescent tags. And so for a given cell surface marker, we might have an antibody against that cell surface marker that's tagged with FITC or with any number of other colors. And depending on what that mix of antibodies is, you need to be able to have fluorescent detectors in the flow cytometer that can detect multiple colors so that you can tell all the different cell surface markers that you're interested in. And we'll get into it in a second, but basically those cell surface markers are characteristic of a cell's developmental stage. So remember that during development, we have development of B cells, of T cells, of myeloid cells, and I'll show a slide of that in just a second. But those cell surface markers are different in those different stages. And so flow cytometry interpretation for leukemias is really about a pattern recognition. So does this sample look like a wide number of cells in normal development, or do we have this abnormal population that might be our leukemic blast? Remember that leukemias represent a clonal expansion, and so you might have a mix of normal and aberrant cell surface markers. So if you have all kinds of markers that suggest this is an early pre-B cell, Well, that's probably a cell that was stopped at that stage of development and clonally expanded. And so you'll have those normal cell surface markers, which can tell you kind of what stage this leukemia is at, but we'll also have some aberrant markers. And these are really important for following disease. So if you have an unusual marker that wouldn't normally be found on an early B cell, you can follow that through treatment and figure out what percentage of cells are still present. So I'm going to show you a couple examples. I'm not trying to turn any of us into flow cytometry experts, but maybe just looking at a few plots so that you can get an idea of what they mean. So during analysis, those blast cells are what we call gated. So they put a circle around them. They often make them different colors so that visually you can tell these are your blast cells. And then they're analyzed for cell surface expression. So if we go back to the stem cell theory of hematopoiesis, remember that from stem cells, we get myeloid progenitors and we get lymphoid progenitors. And the lymphoid progenitors we'll start with are going to give rise to B cells and T cells. And there's multiple stages of development within each of those lines. But if it's a lymphoid progenitor that then goes through some form of development and stops and expands clonally, we'll either have B cell leukemia or T cell leukemia. On the left side, there are a lot more ways that you can get AML. From the myeloid progenitors, it goes on to make the platelets, the basophils, the eosinophils, monocytes, et cetera. And so we have lots of subtypes of AML. So again, remembering that there's a clonal expansion at some point. So I don't expect you to read all of these, but you've probably heard of different CDs, CD34, CD45, et cetera. And so what I'm trying to show you here is that during B cell development, you have a variety of cell surface markers that come and go. So CD34 is a marker of early stage development, whereas CD20 does not come on until later. So if a leukemia is expressing CD20, you expect it to be later in the developmental stage. At the same time, what I was trying to represent over here is a small panel of markers that we might put into flow cytometry. So you see CD45 is a hematopoietic marker. It's positive for most hematopoietic cells. In this case, I have it tagged to a red fluorochrome. Okay, so the idea is you have an antibody, which is your upside down Y here, that targets CD45 and is conjugated to a fluorochrome. We have a different antibody for CD3 with a different color, CD34, CD19, and lambda. So just within a mix of these antibodies, they all have different colors, and you can simultaneously look for all of those cell surface markers. So this is a typical analysis of a leukemia sample. So let's start with on the left. So this is just looking at CD45 on the bottom, on the x-axis, and I told you that marks most hematopoietic cells. So it's going to mark almost anything in that hematopoietic lineage. On the left, this is a side scatter plot. It represents size and content, and so this is a typical pattern where you see the granulocytes, the monocytes that are labeled in green here, and we've gated that orange is our leukemia blasts in this population. To the right of the regular lymphocytes. So we do have a mix here, and we'll come back to this plot, but this is where they tend to start. And then they gate on that orange, and they look at what are all the markers that are expressed in those orange cells, okay? So on the right, you see on the x-axis lambda, and on the left, kappa. So if you look here, you see that all the cells, so the farther to the right would be strongly expressing lambda, the farther up would be strongly expressing kappa. So all of these cells seem to be expressing only lambda, okay? By the time they get to only lambda, they're pretty far along, okay? That's pretty mature B cells. We're gonna come back to that in a minute. The other reason that flow cytometry is so important is this monitoring. So this just shows you minimal residual disease, or we call it MRD, at the end of induction. So remember, end of induction is about 30 days, 29, 28 sometimes. But the idea is we can look at minimal residual disease and tell how well the patient is responding to chemotherapy. We know that they should be in remission by about a week or two into chemo. If they still have residual disease after a month, they need more intensive therapy, and there are different regimens that are used. But what you see here are two different patients. The top one on the left is at diagnosis for this patient. Excuse me. And in this case, the blasts are labeled in green. I don't know why, but everybody uses different colors when they gate their blasts. So you just have to know what it is for a given. So in this case, they're green. You see at day 29, they can put a percentage around those green cells. And that means they have the same markers on their surface that they did at diagnosis. And they're saying this might be 5% MRD or 0.5%. It's very, very sensitive. Can go down to around 1 in 10,000 cells. And it's very quick. I told you get flow results within in a few hours. So by the next day, they'll know whether MRD is present or not. Same thing on the right hand. In this case, the green cells, you see the tumor residual at day 29. So this is very important because we now know that there's a very strong prognostic value. I mentioned that if they have MRD at day 29, this is very, very suggestive of poor response and high relapse rate. So this is from one of our Global Hope slides, and we really try to focus a little bit on the 6 key pediatric cancers from the WHO. ALL is one, and there's a big focus on it because, as I told you this morning, the potential for survival is very high. We know that if we treat these kids right, we can get up in the 80 to 90% survival. And so we're really trying to push flow cytometry even in low resource settings because it's rapid. I mentioned that's really critical for us, and it's also quite cost effective. So I already talked about Global Hope, obviously a capacity building program in sub-Saharan Africa. Again, our sites and our really big challenge, right? We have a very poor outcome. In fact, at most of our sites right now, we're trying to improve 1-year survival rates, right? So it's a little bit different than thinking about long-term survival. We're trying to up our 1 year right now. So we also talked a little bit about the diagnostic challenges in sub-Saharan Africa. There's a heavy reliance on H&E. We can't get immunohistochemistry at a reasonable cost, I would say. So it's often not done, making diagnostic accuracy not always present. As I mentioned, fine needle aspirates can also be used for flow, so that's really important because it's easily accessed. So when I started about 5 years ago, this is what we were doing in Malawi. Very complicated. And it's what happens in a lot of flow cytometry labs where you have individual liquid antibodies. And when you're going to run a run, you take all these liquid antibodies and you mix them together in different combinations, and then you mix them with your cells and put them onto a flow cytometer. Pretty error prone, I would say, if you have folks that aren't well trained. And so we were having trouble with our flow in Malawi, partly because of the instrument, so we needed to replace the instrument. So we started thinking about what would be ideal for flow cytometry in this kind of site. One is simplicity, right? So we really wanted to reduce errors, make it very simple for our techs to set up these assays. And the other thing is those liquid antibodies, first of all, we were shipping them from Houston, and they go cold chain. So very, very expensive. Also, every one of them has a different expiration date. So our labs overseas would have all these antibodies, and some of them would expire sooner than others, and so we were wasting a large number of reagents. So we really wanted a better way to do inventory management. We really needed consistent support. I mentioned this morning how hard it is to get good maintenance and quick support. We have instruments sometimes in some countries that are down for more than a year, CT scans included, which is quite frightening when you hear the last talk, right? So we really wanted to work with a company that could support our sites well. And then we're trying to build out, that I mentioned, no hematopathologists in some countries, including Malawi. So we're trying to build up that expertise to interpret flow results and actually have it at a number of sites that can cross-cover for each other. So what did we decide to do? So again, I want to put out the disclaimer, I do not work for Beckman Coulter. I do not get anything from Beckman Coulter, but they're one of the big flow cytometry companies, and they have a very strong interest in Africa, and they understand the setting. And so we've built a partnership with them. What they have are some pre-mixed, dried down antibody tubes. And so what you see on the left, if you have a suspected leukemia, they come already dried down. You mix with your sample and load them on the instrument. So what are the advantages? One, we don't have all that pipetting, right? It just comes dried down. They have to add the sample. It's identical every day. Okay, we don't have that variability in pipetting. It also has freed up our techs to do other things. So the same techs in Malawi that do our flow, I was able to teach the molecular that I talked about a little bit earlier because they suddenly had more time. We don't have a lot of resources for personnel, so things like this are very effective. It's been easy to introduce at new sites, and they ship at room temp. I can't emphasize, it seems so silly, but how much cheaper it is to ship things at room temperature versus at through cold chain. And there's one expiration date for the entire mix. We don't have all these different expiration dates, so we've had reduced waste. What we do then, and at our sites that are still using liquid antibodies, they pretty much still run all of the tubes at the end of induction. What you can do here is based on the way these are run, if it's an AML at diagnosis, we just run the AML tubes at the end of induction. Saves us a lot of money, fewer tubes. So I just want to mention this partnership. This is Kennedy, one of our techs in Malawi, with the instrument placed by Beckman. Basically, they were willing to put the instrument in. And remember, I told you that this is a partnership where they really believe in Africa and providing increased access to these diagnostics. So they put the flow cytometer in, and if any of you have ever dealt with a lab placement, what that means is a company will come in, put an instrument, sounds great, but then all of the reagent prices are jacked up so much to pay for the instrument, okay? That's the typical reagent rental. We call it reagent rental in the US. What they did was they provided the reagents for validation as well as the analysis, and then after we validated, they have made the reagents available at compassionate pricing. So it's not free, but it's certainly not those doubled prices that we were talking about for a lot of distributors there. So this is how we're working to expand this to other sites. We have 2 other sites coming on board right now with these same antibodies. So our hope is that if we have this agreement in place, we can get one, reasonable pricing, but also build up a network where they can teach each other and rely on each other for coverage as well as difficult cases. So I just want to come back to a couple examples. So you saw, and I don't expect you to be able to read all of these, the top left panel is what I told you, where it's just an overview of the whole sample by size, and you see the blast gated in orange. Each one of the other panels is those blasts with some number of cell surface markers. And so again, it's about a pattern. So if you have something like this, the second one, we have kappa, which remember, I showed you the kappa and lambda, that's actually from this case. Kappa is negative, very far to the left and down, okay? At the same time, there were a few cute things on this sample. So you see CD20 in the middle, very far to the right, right? So that's positive. CD10 also. And over here, we're negative for CD19 and positive for lambda, as I told you. This is a very mature B cell. It's actually a non-Hodgkin's lymphoma sample, but the bone marrow, which this is, has up at the top about 40% blast. So flow can also give us an estimate of blast count. So this is actually a Burkitt leukemia, overlaps heavily with Burkitt lymphoma, but very common in sub-Saharan Africa. So this gives you an idea of that diagnosis was made within about 6 hours. It's another kid, and this shows you how important this timing is. It's an 11-year-old that had a history of vomiting blood. He was very pale. Remember that that's one of the common features of leukemias. Had a very low hemoglobin and a platelet count of 13,000, okay? I'm not a hematopathologist or a hematologist, but 13,000 is quite low. Am I right? From the physicians? So not as low as some of our kids, but quite low. There's a very specific pattern in here that hematopathologists can pick out. So on the left, now our blasts are in pink. And you see it looks like a flame. This is very characteristic of that type of AML that I mentioned, APL, acute promyelocytic leukemia. These kids can die from bleeding if they don't get treatment within a very short period of time, day or two. There are also a couple other characteristic things for that type. So this is one, remember in my molecular talk I talked about those kids that we could pick out by flow that had APL? This is that type of leukemia. So there are some that we can actually diagnose by flow. Most of them we can just tell they're myeloid or BALL or TALL. But this one has several features. The negative for CD10, which is a strong B cell marker, so it's not B cell. Positive for 64, which is a myeloid marker. And they're negative for HLA-DR, which can be positive or negative on AMLs, but in this particular subtype, it's characteristic. And so this kid was diagnosed with APL and started treatment on transretinoic acid immediately and is doing well. So again, this is a kid that probably would have bled out within another day or two. So what else have we learned from doing this? This is a paper actually from a few years ago in Uganda from our group. So interestingly, in the US, I didn't mention this before, but about 3/4 of leukemias are ALL and a smaller number are AML. Okay, very different outcomes. AML is harder to treat. You need much more aggressive therapy, often stem cell transplant. Figured out from flow that we have a much higher percentage of AML. So up to 40% of leukemias, and this has been consistent across a couple of our countries where we have flow cytometry. Well, that obviously contributes to why we have poorer outcomes as well, right? AML takes more aggressive therapy, fails more often, needs a lot of supportive care, and so it's something that we need to continue to think about if we're going to try to reach similar outcomes as what we have in more developed countries. So just in summary, flow cytometry has been very important for promoting accurate and timely diagnosis across the world. We're trying to really incorporate this into the workflow at our sites in Africa and could be elsewhere. It's greatly enhanced our diagnosis for pediatric leukemias. My little plug, I think partnerships with industry are really critical, and I spend a lot of time talking to companies and trying to convince them that they should not always be worried about profit and maybe be thinking about how to allow everyone access to better diagnostics. Sometimes it is heard and a lot of times it's not, but we'll keep working on it. And then remote access obviously is a way that we can provide pathology support from anywhere. So again, my same acknowledgement slide. So I thank you for your time and happy to take questions.